Results of neglected stricture. In view of recent researches, many of the fundamental notions concerning infiltration of urine have been completely changed, and this condition and its associated phenomena now appear as inflammatory and not as mechanical complications of stricture. Since the time of Volomir, the accepted theory has been that all urethral dilatations and urinary pouches in the region of a stricture, as well as all urinary extravasation and infiltration, are due to the pressure of the urine forced against the weakened, inflamed urethra by the bladder filled to overflowing. The urine was supposed to burst through the urethra and thus to cause these complications. But a certain number of phenomena are unexplained by this hypothesis. These are: 1. Urethral dilatations, abscesses, and urinary pouches in front of the stricture. Such cannot be caused by any urinary pressure. 2. Urinary extravasation or gangrene caused by strictures of large caliber when the back pressure is by no means sufficiently violent to cause rupture of the urethra. Moreover, in direct contradiction to the theory of acute extravasation are the observed facts that: 1. The more the bladder is distended, the less able is it to exert any great force or to produce more than a dribbling stream, even after the urethral right-of-way has been re-established. 2. When a urinary pocket is opened and its urethral orifice found, the urine never gushes out, but flows drop by drop. Indeed, Escat and Cotet go so far as to deny that the clinical picture of mechanical extravasation exists. The terrible straining and agony, suddenly relieved with a feeling of something giving away in the perineum, and soon followed by extravasation, is, it would seem, a description devised to fit a theory. The inflammation assumes one of the following types. 1. Suppuration within the stricture causes periurethral abscess, which A. remains localized and quiescent, B. is absorbed, C. extends into the perineum and scrotum, D. opens into the urethra and 1. discharges and heals, 2. remains as a fibrous sac filled continuously or intermittently with urine and communicating with or shut off from the urethra, urinary pouch. 3. fills with urine and bacteria whose ravages rapidly spread the infection, causing infiltration, extravasation, phlegmon, abscess, or gangrene. 2. Suppuration on the surface of the sclerotic tissue, usually behind, sometimes at, and rarely in front of the stricture, may cause dilatation of the urethra, periurethritis, periurethral abscess, with the associated lesions just noted, or, if the physical and bacterial conditions are appropriate, gangrene of the urethra alone or of the surrounding tissues as well. Footnote: Cotet quotes Veillon and Zuber's law. No gangrene or putrefaction without anaerobic bacteria, and finds in all the cases examined by him that when anaerobic bacteria were present, there was gangrene, and when they were absent, even with extensive infiltration, there was no gangrene. 3. To fill out and complete the theory that these accidents depend solely upon the combination of individual predisposition and bacterial virulence, 2 other conditions may be explained by it. The one, malignant gangrene of the genitals, a spontaneous gangrene extending over the genitals, sparing the deeper tissues, terminating in recovery, occurring in young subjects with genitourinary history or disease, and quite comparable to noma, though not fatal. The other, genital gangrene of old prostatics, long habituated to catheter life, a similar condition, not diabetic in origin, terminating in death. Guillain and Albaran, quoted by Escat. These rare conditions can arise from no source other than a fortuitous combination of soil and seed, comparable to that presented by gangrenous extravasation. Periurethritis. In almost any long strictured urethra, there can be felt, by introducing a sound and palpating the canal against it, irregular masses of cicatricial tissue, occupying more or less of the whole length of the canal. A sensitive nodule in this mass indicates an area of periurethral inflammation that may, at any time, develop into an abscess. Periurethral abscess. With the onset of suppuration in this tissue, there is a sharp septic febrile reaction. The lump grows rapidly larger, more painful, and tender, and it may encroach upon the urethra sufficiently to cause retention. Ultimately, it opens into the urethra, or passes into a chronic stage, or more commonly extends into the perineum, burrowing thence throughout the subcutaneous tissue of the external genitals, the thighs, the groins, and even to the lower belly, discharging at many points and leaving the whole region a mass of fistulae through which the urine escapes, perhaps not one drop passing by the natural channel. In these cases, the patient makes water sitting, the urine escaping as though through the sprinkler of a watering pot. Civial reported such a case with 52 external openings. Urinary infiltration, periurethral phlegmon, or gangrene. Beginning as an acute or a chronic periurethral abscess, or as a gangrene of the urethral wall, the acute infective process rapidly spreads over the perineum and the genitals. The first sign is a tender edematous swelling in the median line of the perineum, which rapidly increases in size and spreads superficially in every direction. If there is gangrene, this spreads with frightful rapidity. If there is not gangrene, the enormous edematous swelling, which may reach the size of a child's head, breaks up into innumerable foci of suppuration, from which pus and later pus and urine pour out. Accompanying all this are shock, severe septic symptoms, and usually retention of urine. It is usual in these cases for the tumor to be extensively infiltrated with urine and to contain one or more irregular central cavities filled with urine, necrotic tissue, and pus. But there may be no appreciable infiltration nor any communication with the urethra, and urethrotomy without a guide may be required for the purpose of relieving the retention. The bladder never becomes gangrenous, though the urethra slough to its very neck. The suppuration and gangrene may leave a urethrorectal fistula, but the cavity of the pelvis is never invaded. Inasmuch as urinary infiltration generally occurs in debilitated persons and is itself a very virulent septic process, it often terminates fatally. Urinary fistula. The periurethral abscess may open and discharge in remote regions, but it usually opens in the perineum. Footnote: Desnos mentions a urinary fistula opening at the lower angle of the scapula. I have seen one that reached the loin. The internal orifice is usually single, however many the outward openings. The fistula, if long and tortuous or branched, contains diverticula which repeatedly close, form abscesses, and discharge. Or they may contain foreign bodies or calculi, or the entire tract may be encrusted with calculus. Prognosis. Blind internal fistulae tend to close unless there is stricture. If they persist, they may form the starting point for abscess or infiltration. Blind external fistulae close spontaneously or after cauterization or curettage. Complete fistulae usually require operation.